Good morning, everyone. Thanks for bearing with me. And thank you all for coming and joining us here this morning. Here are my disclosures. So let's talk a little bit about the prevalence of coronary disease. So, it's anywhere between 80 and 15%, depending on the definition of CAD that you use and the population that you're looking at. There's about 50% of TAVR candidates have multi-vessel disease. But as you can see from this graph here, early on in the earlier trials, the prevalence was much higher. But as time went on and we were enrolling much lower risk patients, the prevalence of coronary disease also decreased, as you might expect. But the mean syntax score is around 14, and about 11% of TAVR patients had left main disease, and about half of these had LAD disease. So to kind of put this discussion into context, here's a clinical case that we see every day, right? So this is a 75-year-old woman. She has the usual risk factors. She presents with progressively worsening shortness of breath, and she's found to have severe aortic stenosis, by the usual measurements, trans-aortic velocity of 4.8 meters per second. Her mean gradient was 60 with a dimensionless index of 0.18. She's deemed high surgical risk, and so she's now considered for a TAVR. She comes to the cath lab for a diagnostic angiogram, and she has this very high-grade LAD disease in that mid-segment. So the question here now is what do you do? So there are some unresolved questions I would submit in TAVR. I don't think we're going to resolve any of these questions today in the next 10 minutes. But really, I think as it relates to coronary disease and TAVR, the question is if and when, right? So do we actually need to routinely revascularize patients with severe aortic stenosis who are undergoing a TAVR? And if the answer to that is yes, what is the optimal timing for that? Is it before the TAVR? Is it during the TAVR as a single same procedure? Or is it sometime after the TAVR? There are currently no large-scale randomized controlled trials to inform these decisions, but our current practice has evolved, I would say, over the last 5 to 10 years based on observational studies, several meta-analyses, and expert analysis. So how are we thinking about this issue right now? So here is the sort of conceptualization, as it were, for this issue. So what are the pros and cons of each point in the timeline? So pre-TAVR, those that think that pre-TAVR is the best time to revascularize these patients feel that there is easier access to the coronary ostia. There's not a bulky TAVR frame in the way of your guide catheter. There historically has been this idea that there's potentially a lower risk of coronary events during the TAVR when you're rapid pacing if you revascularize up front. However, on the flip side, there's clearly a risk of hemodynamic collapse, especially during high-risk PCI procedures if you're doing a PCI with aortic stenosis still on the table, right? And not to mention the risk of bleeding when a patient is now established on dual antiplatelet therapy and now you're going through large bore access and doing a TAVR. On the other hand, post-TAVR, staging the PCI to be done after the TAVR has several sort of nice features to it in that, number one, there's a more reliable physiological assessment that can be made, especially for borderline lesions, right? You're taking the AS and that hemodynamic situation off the table, and you're really in a better position to assess whether the coronary lesions are really of any clinical significance. Clearly, there's a lower risk of anything bad happening during the PCI because the aortic stenosis has been taken care of. There is some evidence also that there may be a reduced risk of stroke. And there's also the benefit of perhaps a lower risk of bleeding. However, there is the concern about challenges with access to the coronary ostia, especially with self-expanding valves. The idea of doing PCI in the same sitting as the TAVR has kind of fallen out of favor, I would suggest. I mean, the rationale was that there's no need for additional vascular access. However, it certainly increases the contrast usage, procedure times are much more increased, and there's certainly additional cost. But there was also data from this registry from some years ago now suggesting that if PCI and TAVR is performed during the same hospital admission, there is higher mortality, more complications, and higher cost compared to if the TAVR is done alone.
You know, Prashant, if you go back to the previous slide, it's kind of interesting. You may have missed it because you were rounding the ICU. I showed the country's database, which shows an in-hospital mortality of 1%, right? And if you look at TAVR only here, in-hospital mortality is 4.6%. So it's such a skewed patient population that come in with coronary artery disease, I think.
Correct. No, it's a good point. And it segues into this next slide, which is data from a prospective observational study over about 12 years, over 600 patients undergoing TAVR. And basically, this is just to say that when you do have concomitant coronary artery disease, especially with anatomical complexity, these patients who undergo TAVR, they're associated with a worse 5-year outcome. However, the interesting point to make here, though, is that angiography-guided PCI in these patients made no difference, right? So if you're doing PCI on these patients, there was no real benefit, and there was certainly no clinical advantage. So here is some meta-analyses then that have also been published. So this is, again, all the studies looking at TAVR with PCI that was performed either prior to or during the TAVR or the same hospital admission. This is data from over 5,000 patients and 11 studies. And again, both when you look at the 30-day and 1-year mortality, pre-TAVR PCI offers no additional clinical advantage. This is a more recent meta-analysis looking at the same population now with 24 studies and over 12,000 patients. And we see the same results in that pre-TAVR revascularization with PCI did not improve 30-day or 1-year mortality, and if anything, was associated with a higher incidence of life-threatening bleeding. This was a randomized clinical trial looking at this question, and is the only randomized clinical trial so far that we have. 17 centers, but a very small sample size of only 230-odd patients with severe aortic stenosis and coronary disease patients with a low anginal class, randomized to either PCI or no PCI before TAVR. And as you can see, there was no difference in the primary endpoint, which was death or rehospitalization at 1 year, and again, increased bleeding events in the PCI arm. So that's really all we have for data in this, on this topic. But so how are we thinking about, practically, how are we thinking about these patients? So this is how we do it, at least here at Piedmont. I think that there's some concordance across the country when we speak to others at meetings and elsewhere. But we, as we've heard from Dr. Pulsani, we typically start with a CT coronary angiogram. And if that looks favorable from a coronary disease standpoint, then there is no further invasive angiography to be done, and you can go straight to TAVR. However, if there is more than 50% stenosis, or because there's a heavy calcium burden, the coronary CTA is indeterminate, then we move on to invasive coronary angiography, and based on the amount of disease, we make our decision. So I think it's still worth throwing out there the very severe extensive coronary disease with very high syntax scores. I think it's still useful to reconsider those patients into a CABG AVR pathway. And so we're still doing that on occasion as needed. But for those that may not be surgical candidates, the decision then is based on several clinical and anatomical factors, right? So if, for example, there's less than 50% left main stenosis or intermediate coronary lesions or non-proximal stenoses, then we're moving towards using a functional assessment, either FFR or IFR, to determine significance and whether or not it's worthwhile to revascularize. And for more significant lesions, again, then we're back to the same question about timing. So let's assume now that there's a significant lesion, it's clinically significant. How do you decide when to fix these lesions? So I think the anatomical considerations need to be sort of considered with due diligence to the CT angiogram and in discussion with the entire team, because the coronary ostia height, whether you're needing to do a valve-in-valve TAVR, whether there's an ostial left main lesion, whether this is a very straightforward type A lesion, these may push you towards doing these lesions before the TAVR. Whereas for many of the other cases, we wait now until after the TAVR, because it allows us to make a better assessment of how much of the patient's symptoms were due to the TAVR due to the aortic stenosis or due to the coronary artery disease. And so you take off the AS off the table, and then you can reassess the patient and really get a better sense of whether their symptoms are lifestyle-limiting anginal symptoms. There's a lot that's made about coronary reaccess after TAVR valves. I would submit to you that especially with the SAPIEN valve, the balloon expandable valves, reaccessing the coronary ostia really not a major issue. And certainly we have good experience now, even with the self-expanding valves, to reaccess the coronary ostia. So this is not as much of a challenge as it used to be, but still notwithstanding the anatomical considerations that I've talked about. Now, finally, I just wanted to mention this trial, which we are also heavily involved with here at Piedmont. But this hopefully will answer these unresolved questions that I've alluded to today. So Complete TAVR is a large-scale, multi-center randomized controlled trial with a steering committee that also involves Dr. Thirani here, with Pradeep Yadav as the site primary investigator. And this is a trial of over 100 sites in North America. They are pushing for sites in Europe and Asia as well. But this is a trial looking at symptomatic aortic stenosis patients with at least one coronary artery lesion in a segment that is at least 2.5 millimeters in diameter, with a stenosis that is at least 70%. And the patients undergo a transfemoral TAVR with a balloon expandable valve. There's a lot of other data that's being collected from invasive hemodynamics and transthoracic echo. But after the TAVR, the randomization then occurs within 96 hours of the TAVR. And patients are randomized to either complete revascularization of all the lesions that qualify versus medical therapy. So PCI versus medical therapy after the TAVR has been done. And follow-up is at 3.5 years with a primary endpoint of cardiovascular death, MI, revascularization, hospitalization, etc. So this will be a very interesting trial, and I think will give us the information that we need. They're looking to randomize about 4,000 patients, and we look forward to hearing the results of this. So going back to the patient that I described initially, here was the patient now post-TAVR. So her initial presentation was with shortness of breath. She got her TAVR valve implanted. Now that she was less short of breath, she was more functional. But now that she was able to walk upstairs and do other things, she started developing exertional angina, which previously we hadn't seen because she wasn't that functional. So now we see a very high-grade stenosis in the mid-segment, and we then opted to bring her back to do PCIs. So this is a 7 French guide through the right radial. We negotiated a subclavian loop without difficulty. There was no trouble getting a 7 French guide to intubate the left main. Very, very heavily calcified by IVUS, as you can see here, very thick concentric ring of calcification. We used orbital atherectomy to debulk this lesion, followed by balloon angioplasty. There was a little bit of waste. We actually followed up with intravascular lithotripsy. And you can see here we got a very nice fracture at 12 o'clock. You'll notice here just in a moment right there. That's the sort of fracture that you need to see before you can go ahead and implant a stent. We were comfortable that this lesion would now expand, and we were able to get a nice final angiographic result. And the only point, the 2 points I want to make here is that complex high-risk PCI can be done safely post-TAVR without any challenges of guide engagement, number one. But number two, had we run into issues with no flow or slow reflow with this patient during the atherectomy portion of this case, the aortic stenosis would have caused many more problems for us, right? So being able to take the aortic stenosis off the table and treat this lesion with atherectomy makes, I think, the case a much safer case. So in summary then, this is my last slide. There are currently no large-scale randomized trials to inform clinical practice on the benefits and timing of PCI in these patients that are undergoing TAVR. Currently, the decision to perform PCI is an individualized decision based on clinical factors, angina, ischemia, risks of bleeding, as well as anatomical factors, the lesion location, complexity, the technical feasibility of guide engagement, and so on. Overall, the data that we do have to date, the non-randomized studies, suggest that routine PCI before TAVR really doesn't offer any significant clinical advantage. Conceptually, at least in my opinion, post-TAVR PCI allows for a safer procedure, especially in high-risk cases like the one I've just shown. And I think that certainly a staged PCI post-TAVR has become more of a common strategy, not only here, but nationally. And we all look forward to the ongoing complete TAVR trial for more insights. Thank you.
Great.